Hey everyone, welcome to the channel. Today we're going to be discussing another step 2 CK topic, which is on polyuria and dilute urine. So if a patient comes complaining of polyuria, how do we know if this is true polyuria or not? So we get a 24-hour urine collection, and if that patient has a urine output of more than 3 liters per day, that's when we will say it is true polyuria. So today we're going to be discussing three main pathologies associated with polyuria and dilute urine, and these are primary polydipsia, central diabetes insipidus, and nephrogenic diabetes insipidus. So let's get right into it. In primary polydipsia, we don't have any issue with our ADH mechanism, so it's not an ADH problem. It's simply that the patient is drinking excessive amounts of water. In central diabetes insipidus, your body is not producing enough ADH. So there is ADH deficiency. And this is most likely going to be a CNS pathology. In nephrogenic diabetes insipidus, we have ADH being produced by our body, but it's not working on the renal collecting tubule cells as it's supposed to. So there is ADH resistance. So why does this happen? Why do these three conditions happen? So in primary polydipsia, a patient might be suffering from a psychiatric condition that causes him to drink excessive amount of water. Or maybe the patient is taking antipsychotics, and one of the side effects of antipsychotics is having a dry mouth. So that might be leading him to drinking excessive amounts of water. Then the reason for central diabetes insipidus can be many. It can be because of trauma. It can be because the patient had a surgery, pituitary surgery to remove perhaps an adenoma. It can be because of ischemic encephalopathy. Or it can be because of a reason we don't even know, so like idiopathic. Nephrogenic diabetes insipidus, you might have heard patients with bipolar disorder, they use lithium. So chronic lithium use can lead to nephrogenic diabetes insipidus. Then hypercalcemia and hereditary mutations of aquaporin channels can also lead to nephrogenic diabetes insipidus. So how do we differentiate between these three etiologies? We have two main tests that we do. There is the water deprivation test. So essentially in this test, we deprive the patient of water. We don't give them water for a few hours, and we measure their urine osmolality and see how it changes. So in primary polydipsia, patient is drinking excessive amounts of water. Now that you've deprived the patient of water, we know that the ADH is being reduced normally by the body. So ADH will try to conserve that water, and before, if the patient had urine of low osmolality, now they will have a urine of high osmolality. In central diabetes insipidus and in nephrogenic diabetes insipidus, depriving the patient of water will have no change, because we know that the ADH mechanism is defected, right, in the first place. The second test that we do is checking their response to desmopressin. So desmopressin is an ADH analog, and in patient with primary polydipsia, giving desmopressin will have no effect because already the ADH mechanism is in place. It's working properly. In central diabetes insipidus, since we know that there is a deficiency of ADH, now that we're supplying the body with that ADH in the form of desmopressin, our urine osmolality will increase. And in the case of nephrogenic diabetes insipidus, again, there will be a no change, because although you're giving the body ADH in the form of desmopressin, it's not working properly because there might be a problem with the receptors. And so there is ADH resistance. So in primary polydipsia and in nephrogenic diabetes insipidus, giving desmopressin will have no effect. So that was about it for polyuria and dilute urine. And if you have any further questions, you can comment down. And if you like this video, please give it a thumbs up and subscribe to this channel for more video content.